Dear Chair and dear audience, welcome to my 6 months progress report. I would like to introduce you my PhD thesis title, which is New Approaches in the Management of Oncological Patients. My name is Renáta Árok, and I am a hospital and clinical pharmacist and a first-year PhD student as well in the Department of Dermatology. My vision is that oncological patients could have a better quality of life. Therefore, my mission is to find the most effective treatment and appropriate management of side effects in oncological patients. Currently, I have 2 ongoing projects, which will be a systematic review and a meta-analysis. My first project is investigating the efficacy of preventive and therapeutic options for kinase inhibitory therapy-induced skin toxicity. And a few words about the background. There has been a tremendous shift in cancer treatment for the last 2 decades. Oncological indication approvals has risen, driven by targeted therapies. Moreover, a number of these agents were in the top-selling cancer drugs in 2022. As you can see in the figure, kinase inhibitors have the highest number of approvals, almost 30%. So we can see that the use of them is continuously rising. But unfortunately, they have the highest rate of occurrences of serious side effects as well, which can be up to 90%. So it is a crucial issue because patients can easily interrupt their oncological treatment because of these side effects. This occurs up to 76%. Interestingly enough, in healthcare, there are many prevention and treatment options with no consensus. So my aim is to find the most effective preventive and therapeutic options for kinase inhibitory therapy-induced skin toxicity. My clinical question is the same as my aim, which is actually follow the PICO framework. So we are planning to investigate the prevention and treatment options compared to no prevention, no treatment, and placebo, with the outcomes of efficacy and compliance to targeted therapy. Our hypothesis is that the implementing of prevention and treatment results in higher compliance to the original oncological therapy. So I conducted a systematic search at the end of November, and this slide and the next slide depict my search key and my flowchart of selection. The number of articles I found are overwhelmed, and eventually I have 77 eligible full texts. Let me move on to the preliminary results. We have 2 outcomes, the incidence of skin side effects regarding to prevention and the improvement of adverse events in connection with treatment. The outcome measure is odds ratio with 95% confidence intervals. Currently, I am working on the remaining articles in which other pharmacological groups are investigated, and until now, I finished the analysis of preventive effects of antibiotics. Here is my first figure of my results. In this figure, we are analyzing the incidence of skin toxicity using systemic prevention with tetracyclines for a short and long-term follow-up model. This figure summarizes the RCTs. And there are 2 agents in tetracycline groups which we investigated. The outcome measure was odds ratio, and we found that the incidence of skin toxicity decreased almost 50% if patients received antibiotics. Our results was statistically significant and clinically relevant. In the second figure, we are analyzing the same outcome in all studies, in which the interventional agent was one of the depicted tetracyclines. Our measure of effects was proportion, and we found that the occurrences of skin toxicity was almost 60% of the total events. Our results was statistically significant. However, the heterogeneity was quite high, 70%, presumably due to the various study methods or different follow-up times. I must emphasize as strengths that I have mainly RCTs, which have high patient number and wide range of treatments. In connection with limitations, I would say that there are various study designs, and the definition of skin toxicity were also variable. In conclusion, I would say that skin toxicity can be prevented with tetracyclines. Therefore, the quality of life of patients can be improved, also the interprofessional collaboration, and with this, the discontinuation of the original oncological therapy can be avoided. However, more clinical trials are needed with a similar methodology. So here you can see my progress of my first project. Currently, I am working on the data extraction part. And let me move on to the second topic, in which we are planning to compare the efficacy and safety of pharmacological therapies for advanced cutaneous squamous cell carcinoma. Cutaneous squamous cell carcinoma is the second most common human cancer of non-melanoma skin cancers. Its incidence is 1.8 million per year, which is predicted to increase by 50% by 2030. Cutaneous squamous cell carcinoma is considered as advanced when it is or it has spread or can be cured by surgery or radiotherapy. It has two forms, metastatic and locally advanced. The systemic therapy is a challenge because of the generally poor condition of patients. The current therapies are chemotherapy, targeted therapy, and immunotherapy. Because of the high mutational feature, cutaneous squamous cell carcinoma would be a good candidate for immunotherapeutic agents. So my aim is to find the most effective and tolerable therapeutic option for cutaneous squamous cell carcinoma. My clinical question is, what is the safest and most effective treatment for advanced cutaneous squamous cell carcinoma? And I am planning to compare the immunotherapy with chemotherapy and targeted therapy with the outcomes of survival, recurrence rate, and adverse events. Our hypothesis is that immunotherapy is superior to chemotherapy and targeted therapy in this condition. And our clinical and research implication is the early use of immunotherapeutic agents can improve patient survival. Here you can see my preliminary search with my search key, but my topic visible is currently ongoing. So in summary, I would say that I have 2 ongoing projects, and I hope I will finish them in this year. And thank you for your kind attention with the Eleanor Roosevelt's word, "You must do the things you think cannot do." Thank you.
Hi, congratulations. I wanted to ask about your first topic, about the prevention with tetracyclines. What is the protocol of administration, and what is the time point? They are administered when the immunotherapy started, or how exactly?
Generally, thank you for a question. Generally, as I remember from the articles, the preventive treatment is started when in the first day when the targeted therapy is started as well. For regarding to the administration part, I don't remember how is it exactly administered according to the articles.
Thank you.
First of all, congratulations for your wonderful presentation. I have a question regarding your first project. Are you planning investigating other outcomes besides the compliance and efficacy?
Yeah, thank you for a question. I am planning to investigate other outcomes as well. The quality of life, but currently I have a few data about it. Yeah, but I am planning.
Thank you.
Thank you for your presentation. I have a question. I'm not sure if you mentioned that, but how was skin toxicity defined among these studies?
Yeah, thank you for your question. The skin toxicities generally are defined with CTCA score. It is a common terminology of adverse events. And there are 5 grades of skin toxicity, and articles generally mentioned these grades. And I think the heterogeneity of results would be would high because of that articles. The outpoint of skin toxicity is different because of the grade.
All right, thank you.
Congratulations on your presentation. I have a question regarding what types of skin toxicities were investigated.
Yeah, thank you for your question. The skin toxicities were mainly rash, acneiform rash, and hand-foot syndrome, and also paronychia and cirrhosis.